Hello, I'm Michael Chen. Um, I'm going to be spending the next 20 minutes talking about an update to stroke thrombectomy. Uh, these are my disclosures. And, we're part of a busy stroke center. We see quite a high volume of stroke thrombectomies. We're involved in a lot of clinical studies. I think a lot of that means that we've confronted a lot of challenges associated with how to better deliver care. And as anybody who's involved in this knows, it's a very complex process. There's a lot of moving parts and a lot of room for improvement. So that's really what I hope to go over today, is just sort of the top 10 things that, I think are important challenges and concepts for us to know to be able to hopefully deliver better care for our stroke thrombectomy patients, those patients with large vessel occlusions. So number one on the list is awareness. I think, as you know, large vessel occlusive strokes involving the internal carotid artery terminus or the M1 segment, although they constitute only about 20% of the roughly 800,000 strokes that occur each year in the US, they account for a disproportionately large amount of the disability that we see for stroke. And this is exactly the type of strokes that endovascular therapy is tailored for. And these types of strokes can lead to extremely disabling large volume infarcts like this and disability where they're not able to take care of their activities of daily living. And what makes it very difficult for stroke in particular is that a lot of times these patients with very severe disabilities are often hidden from society. They're oftentimes in nursing homes or in rehab facilities. And a lot of people in the general public aren't that aware of just what the ramifications of severe strokes can be. And so that's one of the challenges that we have in trying to promote important public awareness campaigns. Any attempts at doing this are oftentimes challenging, as these billboards can show. And even during the pandemic, I think the concern about the transmission of the infect virus in the hospitals may have interfered with people's perceptions of coming to the hospital to receive emergency care, and maybe stresses on the EMS system. So all of these are challenges that we, as healthcare providers, especially stroke specialists, need to really continue to reinforce that effective treatments for stroke do exist, and you can only get them if you come to the hospital. And so, number two on this list is that the treatments are effective. I think most of us here know that since 2015, multiple studies published in the New England Journal showed a very consistent delta in patients with large vessel occlusion, showing much better 90-day modified Rankin score of independence compared to those treated with medical management. The techniques oftentimes relate to either a stent retriever or aspiration. And aspiration is, in fact, the method that has been gaining greater traction now. A lot of startup companies that we're working with now are iterating on these catheters to really optimize aspiration force to make the procedures safer and more efficient. We always love seeing the clots coming out of the body as opposed to being in the brain. And we have cases such as this where you have an M1 occlusion and you bring a catheter up there and able to restore complete blood flow to that territory. And usually, most of the time, our patient procedures are done in about 20 minutes or so. And this is the type of MRI we're hoping to achieve, where the patient is able to be discharged home. Not all the time, though. It's a lot of times the patients can come in perhaps with poor collateral scores or premorbid levels of disability. They have an occlusion like this, a right ICA occlusion. You're able to restore blood flow completely, and angiographically looks like a very satisfactory result. However, there still is too much irreversibly injured brain. The patient has severe cerebral edema, and this is a life-threatening situation. So it's important to be aware that the guidelines that were published after publication of these positive studies include that there's level 1A evidence now for patients to receive endovascular therapy if they have a low premorbid level, pre-stroke level of morbidity, if they've received thrombolytics, if they have a large vessel anterior circulation occlusion, if they're over the age of 18, if they have an NIH stroke scale greater than 6, which is the severity of their stroke deficits, if they have an aspect score, which we'll go into in a little bit, greater than 6, which suggests not too much irreversibly injured brain volume, as well as you're able to start treatment within 6 hours. However, what's interesting is that even the meta-analysis called the Hermes meta-analysis, looking at over 1,200 patients randomized in these thrombectomy studies, found that the number needed to treat was actually around 3, which makes you think that perhaps our screening or inclusion criteria may be too strict, which is great for the patients who can make it. But for those who are on the borderline, who have one of these criteria may not necessarily fit, who would have been excluded, they may still benefit, because I think many of us would be willing to and accept a number needed to treat a little bit higher than 3. So that's where a lot of work has been done, is going on right now in terms of evolving patient selection criteria. At Rush, we're involved in several studies trying to iterate and improve patient selection criteria to look for perhaps more modest benefit, but still benefit. And that way, I think we can, potentially improve access to greater numbers of patients with large vessel ischemic strokes. Part of this is knowing aspects. Aspects is essentially like the NIH stroke scale for the neurologic exam. It's the aspects is basically like your way to quantify your evaluation of the plain head CT. Basically, you look at one level of the plain head CT at the basal ganglia, and you look at another level above the basal ganglia. You divide it into 10 segments. Anywhere there's a hypodensity, you mark it as a point off, 10 being normal, 0 being completely involved. So practically speaking, most of the patients who were enrolled in these clinical studies that showed effectiveness were aspects, had a tiny or small infarct core, aspects greater than 6. But there may still be benefit in those patients with medium aspect score, between 4 to 6. And that's why we're actually enrolling subjects. We actually have about 4 subjects or so enrolled in the SELECT-2 study, which is looking at patients with low aspects and large vessel occlusion to see if they still might benefit from thrombectomy. I think anybody would realize that, although not independent, I think patients with this who happen to have a stroke would much prefer being able to transfer out of a bed independently versus being completely bedbound. So those are the new outcome measures that are going to be evaluated for. And I think it's important as we further develop, there are outcome measures for thrombectomy. So in isolation, low aspects should not deter consideration for thrombectomy. It should be used as one of several variables in making your decision. The next, besides knowing your aspect, is much like voting in Chicago, get a CTA of the brain early and often. Stroke is a disease of the blood vessels, and I think it behooves you to, as best as possible, try to get some pictures of the blood vessels to help you understand what's going on. I think an example like this, you get a CTA in the emergency room early, you're able to know exactly what you're dealing with, and I think that helps you with your management decisions. One case that I really, really like is Dr. Sherian, I think, was evaluating a patient with an NIH stroke scale of 2, just some dysmetria and dysarthria, but based on her telestroke evaluation, had a suspicion there may be something more ominous, ordered a CTA at the outside hospital despite an NIH stroke scale of only 2, and found a mid-basilar occlusion. Likely the score was this low because of collateral blood flow. And so she decided to transfer the patient for closer monitoring, and sure enough, upon arrival, the patient declined and became comatose. We brought him into the angiography suite, and luckily we were able to perform a pretty quick thrombectomy and had a pretty nice outcome for this patient. We are also very, very close to beginning enrollment in the ENDOLO study, which is looking at large vessel occlusions and an NIH stroke scale less than 6. And I think this will provide a lot of insight, because yet another difficult conundrum for us are those patients with pretty mild symptoms and a large vessel occlusion. Should we take them immediately for a thrombectomy, or perhaps, quote, wait until they decline? So that's a real hard decision to make. We've encountered it many times, and I'm glad the study is going on, and I think it'll provide us a lot of insight into seeing just how these patients might do depending on which option you take. So next on the list is to think collaterals, not elapsed time. Since 1996, since the FDA approval of IVTPA, time had been historically used as the surrogate marker for the amount of irreversibly injured brain or the amount of salvageable brain. It was very convenient, easy to measure, but as you might imagine, it sort of relies on population averages and perhaps doesn't account for individual variations. And so I think it's probably better and more evolved now for us to consider collaterals rather than just time. As you can see here, there are two patients here with the same M1 occlusion. The patient on one side has very extensive collaterals from the anterior cerebral artery coming to supply blood, albeit in a delayed fashion, to that whole left hemisphere convexity, whereas the other patient has no collaterals. So you can imagine that these two patients are able to sustain that salvageable brain for varying amounts of time, sort of holding their breath, so to speak. And that's generally the term I like to use. I'm talking to patients. If the brain is holding its breath, the sooner we can restore blood flow, the better the chance we can, have some salvageable brain restored. But I think it's important here that we use imaging to determine whether the collaterals are there, rather than just absolute time thresholds. Yet another seemingly more basic issue that I actually see again and again in patients who are transferred are patients who have high blood pressure being treated by the paramedics or the EMT upon arrival. And it's important to realize, anybody who's taking care, especially for large vessel occlusive stroke patients, that during a stroke, their autoregulation reflex is impaired, and the ability to maintain cerebral blood flow at lower blood pressures is not so efficient. So you really need to maintain higher blood pressures to be able to optimize cerebral perfusion pressure. So that's one thing, just don't aggressively treat hypertension. The next main issue that we are really working on and trying to address is pre-hospital triage. So most patients come to us going to an outside hospital from an ambulance, getting IVTPA, and eventually making it to us for thrombectomy. And this is about 90% of our stroke thrombectomies occur this way. Only 10% of all stroke centers are endovascular capable to provide 24/7, 365 thrombectomy care. And as you can see here, though, however, many of the positive thrombectomy studies that were published in 2015 did have a rate of good clinical outcome of about 60 to 70%. But their average time to treatment, if you look here on the x-axis, was about 4.5 hours. So you might imagine, what if we could potentially reduce this time to treatment from 4.5 hours to maybe 2 to 3 hours? You can only imagine, if we were to continue drawing this line, that you might have 90% of patients with good clinical outcome on average. So that would really be the lowest hanging fruit in terms of trying to improve outcomes for patients, just bringing patients to hospitals sooner than the 4.5 hour average that we normally see. And that's what we see right now too, here at Rush. So that begs the question, is it possible to bring patients straight to a comprehensive or endovascular capable center? That it's not so easy. There's a lot of legislation, public education to try to get severe stroke patients triaged, much like trauma patients or like STEMI patients, where they are brought to centers that can provide the specialized care that they need. But it's not so easy. It's a very complex topic. I could spend a whole nother talk talking about that. Suffice it to say, there is a lot of investment in pre-hospital screening technology to try to achieve this sort of diagnosis of a large vessel occlusion in the field. And there are also, sort of looking at it in a reverse way, so a lot of investments from different companies to try to invest in endovascular robots that could be controlled remotely so that patients could be treated at their local hospital. I just got off the phone yesterday with a startup out of California that are trying to use AI and touchscreens to develop robots that could be controlled remotely to decrease time to treatment for patients with large vessel occlusions. So despite all that promising stuff in the future, we still rely on the good old telephone. And a lot of these, it just requires us to try as best as possible with the technology that we have available to try to improve the sophistication of our interhospital transfers. And a lot of times there's a lot of information that's being exchanged on the phone. There are a lot of things we try to accomplish, and having a video remote link in is very helpful, and having a telestroke network is also very helpful. But still, there's only a limited amount of information. And as we see here in a study for 2 years after, from 2015 to 2017, over 50% of the roughly 200 transfers that occurred to Rush actually didn't go for thrombectomy. And that's an issue, especially if that number gets too high. there's a lot of resource utilization once we are holding a room, bringing staff in during the off hours, transferring patients sometimes via helicopter, and opportunity costs that need to be concerned. So it just this really comes up and becomes a bigger issue when we're talking about patients, off hours, older patients, and then do we use age cutoffs? I think we all know older patients generally don't do as well as younger patients, despite great procedural results. Should we try to determine the premorbid status instead of using the numerical age? We've got a sense of how independent the patient is, if they're able to be left alone. This type of obtaining historical information can be haphazard at times. So I've been pretty excited to be working on a project with one of the medical students here at Rush, where we combine data with the University of Buffalo to look at the degree of cerebral atrophy and leukoariosis using a very simplified scale, looking at central atrophy, measuring the ventricular width, as well as cortical atrophy, looking at the sulcal width in combination with atrophy. And we found actually in our cohort of about 175 patients, all over the age of 65, all with TK2b3 recanalization, that depending on the degree of atrophy, it did correlate with worsening functional outcomes at 90 days. So this might be an indication that we can use perhaps a more accurate biologic composite of pre-stroke level of functioning based on imaging, rather than trying to obtain this through history. We are also trying to look at if there's any way we can evaluate the eloquence of each brain region, rather than treating each brain region the same, which the aspect score implicitly does. Which what we did find too was in a study looking at our own patients, that different aspects regions correlate differently with disability. And accordingly, based on the left and right side, I think this may allow us to have more sophisticated interpretation of the aspects going forward to help us select patients. The last point on this top 10 list is that none of this is easy. And what I mean by that really stems from, I think, a study you may or may not have heard of, looking at a good number of Israeli judges trying to try cases on various crimes, and found that their percentage of punitive decisions averaged around 15 to 20%, but consistently went up to about 60 to 70% right before their lunch break or their other break. And then after the break, those rates of punitive decisions actually went down again. This was sort of observed over a long period of time, and really a very solid trend was noticed, which raises a question about whether or not these judges were making their decisions purely based on the facts of the case, or were their personal, how they were feeling affect their decision making. And I think this is very relevant to stroke. We get called in the middle of the night. I'm on call a week at a time. The stroke neurologists are constantly bombarded with so many consultations all day long, all night long. I remember one time I had one case, and the stroke neurologist, during that time of only one case, they did about 3 or 4 consultations via telestroke. And it's just, it can be close to burnout sometimes, but I think that workload can affect your ability to make an effective decision for your patients. What makes this particularly hard is that when you're tired or sleep deprived, you may rely more on implicit decision making, which is those that involve mental shortcuts, subject to maybe more biases and error. Whereas for something as complex as stroke triage, inter-hospital transfers, we really need to rely more on explicit decision making, where it's more mentally taxing, but we list out all the different factors, discuss it, use logic evidence, and hopefully be less prone to biases. Many of these decisions are definitely not black and white. The more information you can get, such as the age, premorbid status, core, and I think you're able to more precisely place this patient along this scale of whether or not we should really pursue thrombectomy. And I think it just calls into, brings into attention that we really need to genuinely practice refereeing of ourselves. This is an invisible yet powerful force. We need to make the right decision despite self-sacrifice. You may have to come in at 2 a.m. despite not getting sleep the last 2 nights. And this requires practice, because when you really need it is when all that practice will come into help. And that then this is why I think there's particular value for us to have our cerebrovascular conference every week, where we review cases and really focus on these challenging decisions, and I think try to make the whole process more transparent. And I think then as a team, we're able to sort of empathize with each other and see how we make our decisions, and hopefully that informs us during our next time when we're on call. So that's the top 10 list of updates for stroke thrombectomy. And look forward to talking some more during the Q&A session later on today. Thank you.